I will talk later about diabetes, but I'm going to be talking for the next session on subclinical thyroid disease, basically subclinical hypothyroidism. And the major focus is on screening for thyroid disease, because when you screen, we are finding a lot of people with subclinical disease, minor abnormalities in thyroid function tests. People get very anxious about it. And it's a very common reason for referral, either self-referral or referral for other physicians. It's also important from another perspective. Once people start on thyroid hormone replacement, it basically becomes lifelong. Very few people are, have the guts to stop it in somebody who's on stable treatment. And there's a certain proportion of people who are being treated inappropriately, and it's not without consequences, with osteoporosis or later in life atrial fibrillation, etc. So I think it's very important to do this and be very careful about starting treatment. So the ACP guideline, which came out maybe about 10 years ago, stated that it's very reasonable to screen women older than 50 for asymptomatic thyroid disease. It's a very simple test to do, and with a sensitive TSH, and you can get a wide combination. You can get a low TSH, high T4. You heard about this already. You can get a low TSH, normal free T4, which some people call subclinical hypothyroidism. Personally, I'm very skeptical about using this kind of test, because when I do thyroid uptakes and scan, most of them turn out to be normal, and many of these people manage without having any problem for a long period of time. You can get overt hypothyroidism, which I will not spend much time on. But a real common problem is this one of subclinical hypothyroidism. So how do we define it? High TSH. TSH, what is high varies a lot. In our hospital, the upper limit of normal is 4. Some labs have 5. Some people say more than 6 is abnormal. But actually, there's an age dependency. So as you get older, even 6 is quite normal. There are a number of studies now pointing out that older people have perfectly normal function without any progression with levels of 6 and 7. And here are the levels of T4 and T3 that I won't go into. So if you look at the prevalence, this is a very common problem, probably after diabetes, the most common endocrine problem that's out there, about 5 to 10% of the general population, and 7 to 26% of studies in the elderly, because the elderly, it is normal in the elderly, so I don't consider it prevalence of an abnormality. And most of these people are actually, in the 5 to 10 range. So what do you do with them? So it's, as I said, common in the elderly. What are the causes of hypothyroidism? You know most of this well. A couple of things that I want to point out is the recovery from sick euthyroid syndrome. It goes through many phases. Initially, the TSH and free T4 are low. Then the TSH actually recovers and sometimes overshoots. So if you have somebody who's been very sick, even with a bad flu-like illness, and you catch them at the wrong time, you may have a TSH of 8, and they will recover within a few weeks. So you need to watch out for that and get a prior history. Medications, we are using less and less of amiodarone, but it is an important cause and a very challenging one to treat. But we now have alternative drugs in that area. I don't know why this is moving that way. Lithium is actually a very common cause. There are a few other medications that I want to mention that I think are very important. There's been a dramatic advance in the treatment of cancer with monoclonal antibodies, again, targeting the immune system, and so-called checkpoint inhibitors. These are causing very severe autoimmune disease, including type 1 diabetes, lymphocytic hypophysitis, and very severe thyroid disease, acute like thyroid crisis. And it really makes us think and rethink about what is the etiology of this condition. So I see a number of patients with, and as more and more patients are treated with these conditions, you will find that there are some who have mild disease and borderline disease, and you're going to have to deal with this in the future. Another very common probably one of the commoner causes that I see are interference with the assay by commonly used over-the-counter medications like biotin. So a lot of middle-aged women are taking biotin preparations for brittle nails, falling hair, non-specific symptoms, and they don't tell you about it. And you will get a mild abnormality. Slight TSH can go to 7, 8. And I always ask this question and ask them for what over-the-counter medications, or even look at it, and you will find biotin-containing compounds. You need to stop it. Some people say it goes back to normal in 2 days. Some people say 1 week. I usually tell the patient, wait for a couple of weeks, retest. And I end up warning these people whenever they're having repeated testing not to take biotin for at least 2 weeks because the assays become uninterpretable. This is not because biotin causes a problem with the thyroid. It's because of the assay where there are certain components with most assays that are commonly used in labs that interfere with the measurement of thyroid hormone. Then, of course, you have people who have previous radioiodine or surgery, and, of course, pituitary disease. So the prevalence of this is fairly common in elderly people. Actually, look at the percentage of people, particularly elderly females, almost 20% will have a high TSH level. And this is another way of looking at the same thing, particularly in women 70 to 80. Much more problematic is the symptoms. So you see here that symptoms are quite common in hypothyroid patients, and these are mainly, many symptoms of thyroid disease are somewhat non-specific, and they're not that much different from people who have mildly elevated thyroid disease, but also euthyroid people, people with completely normal tests will have these symptoms. What this tells me is there's really no difference, and a lot of these symptoms are non-specific, and it creates unrealistic expectations in people that you're going to make them better by giving them thyroid hormone, and they won't feel any different, and then they are extremely unhappy. One of the most intriguing papers I've come across in the last 1 year is a paper from Europe where they took people who had continued symptoms on thyroid hormone replacement and thyroid antibodies, and they randomized them to receive surgery, a thyroidectomy, for Hashimoto's disease or not. And there was a greater reduction in symptoms in those who had had a thyroidectomy. I think it's very premature to make a recommendation on that. There'll be lots of surgeons who now want to do thyroidectomy in people who have Hashimoto's disease. Personally, I think this needs to be repeated, and I'm skeptical that you will get any relief of symptoms on a wide scale. But that's where it is. And these are the symptoms. Dry skin, sounds like me, poor memory, slow thinking, generally fatigued, and hoarse voice. I have all these symptoms myself. So these are the percentages higher than normal people. And what we really want to know is how many people are going to progress. Those are the people we want to treat before they get complications of hypothyroidism, particularly people who don't go to the doctor very often. You want to treat them before they have a problem. And you also want to treat cardiac and pulmonary function abnormalities that are associated with it. And something that has been in the attention of people for a long, long time is hyperlipidemia. So let me go through some of these. So what is the risk of progression with somebody who has a TSH of 6 or 7 to become hypothyroid? And it varies very considerably. 20-year follow-up, 55% of women with a TSH above 6 developed hypothyroidism. And 90% of those with a TSH greater than 10. Now remember, this is 20 years. So you'll be treating half the people unnecessarily if they present with 6. Now, this also depends on having a good lab with a good assay. And so you want a better way to refine who's going to become hypothyroid and who's not. So one of those things that will help you in distinguishing them is antithyroid antibodies. Here again, you need a good lab that can detect antibodies. And if the antibodies are positive, the chance of it progressing are greater. And it's actually much lower if the patient does not have thyroid antibodies. So this is one of the few indications for doing thyroid antibodies. What about the second thing, which is cardiac and pulmonary function abnormalities? These are described in the literature. We don't pay much attention to the average patient in an endocrinologist's clinic. Impaired myocardial contractility. I'm somewhat skeptical about the importance of this. There have been multiple trials in people with heart failure with replacing with thyroid hormone that have been completely negative. Diastolic dysfunction can occur, but again, it's not definitive that you can correct this in the average patient with these kind of abnormalities. And the patients may also have other reasons for their diastolic dysfunction, hypertension, diabetes, which is more important in causing this problem. There's also decreased vital capacity. That's understandable. You have some degree of diaphragmatic weakness. If you can correct that, that's a good thing. There are a few good large studies. There's the Rotterdam study published in 2000, which showed that subclinical hypothyroidism was an independent risk factor for atherosclerosis and myocardial infarction. But here is the odds ratios. It's actually not that high. This is an association, and the confidence intervals are only a little bit above 1. So I wouldn't say that subclinical hypothyroidism causes this problem. There may be an association because there's more weight gain, there's more hyperlipidemia, but there's also more diabetes in this population. So whether it's this one alone or there are many unmeasured confounders, it's very hard to know. It's a relatively small study for this kind of population. So here are the comorbidities in those who had subclinical hypothyroidism. There was also a lot of dyslipidemia, hypertension, smoking, and diabetes that could have been contributing to this problem. So I take that with a little grain of salt. What is very clear is that there's a relationship between TSH and total cholesterol. So if you have a low if you have your thyroid function tests show a low free T4, you will have a high cholesterol. This has been very well documented. Multiple studies showing that if you replace the thyroid hormone, you will bring down the cholesterol. The problem is that enough, and is it better than a statin? I don't think so. So this is from the past era, that when we had no other treatments for hyperlipidemia, giving thyroid hormone may have been a good thing. What has been of very great interest to the pharmaceutical industry for many years has been to try to develop thyroid hormone analogs that do not work on the beta stimulation receptor and just lower cholesterol. That has actually not panned out. So here is a Colorado Heart study looking at cholesterol levels in people who are hypothyroid, total cholesterol 251, and in euthyroid patients is 216. So there's a big difference between the two. Mildly elevated subclinical hypothyroidism, it's only slight difference. So I would not treat this type of patient only for their cholesterol. You consider treatment for other reasons. So if you look at the benefits of treatment, there are a number of studies looking at this, looking at various symptoms, replacing for 6 months or so, here are 3 studies, and they show that symptom scores improve. So people do feel better on replacement, but we shouldn't be treating everybody unnecessarily because there's certain degrees of risk. So in up to almost 50% of patients with subclinical hypothyroidism, if you give TSH is less than 7, if you do nothing, the levels are normalized within 2 years. In those who are greater than 10, there's an increased risk of further progression of the hypothyroidism and them developing symptoms and maybe cardiovascular events. But there is no randomized controlled trial comparing people with borderline hypothyroidism who received treatment and did not receive treatment and look at cardiovascular outcomes. Even so, there's a consensus of opinion that if people have a TSH greater than 10, we should be treating. So what are the benefits of treatment? You get improvement in the cardiopulmonary function abnormalities that I described before. You get a definite reduction in total and LDL cholesterol. There's no effect on HDL and triglycerides. And the higher your TSH, the greater the fall. So here are people who have borderline subclinical hypothyroidism, TSH of 5 to 9. There's very small reduction. Here you see people who have a TSH that's much greater. They have a much greater reduction in cholesterol levels. There have been other cardiovascular risk factors that have been looked at. There's really no effect on inflammation, etc. There's a very clear reduction in homocysteine levels. Whether that is important or not is debatable. So because of these benefits on symptoms, symptom scores, cholesterol, etc., there have been various guidelines for treating subclinical hypothyroidism. I'm not going to read through these differences between the European and American thyroid associations. Let me just, 1 minute. So there is still some controversy there, and we have to be a little pragmatic in how we treat them. So we have not, it's not as a strong evidence-based treatment paradigm, but the recommendation is that we should try to keep people's TSH between 0.5 and 2 if they are on treatment. And subclinical thyroid hypothyroidism does have some importance clinically. We may need to follow these patients, and many people should be treated. There's some people feel that most people should be treated. I think that it may be true if the TSH is more than 10, less than 10. I personally prefer to watch these people. We should limit the use of LT4 to people whose TSH is more than 10, and you should be testing more than once. I wouldn't go on just one lab test. The presence of symptoms and signs. People who have a goiter because they clearly have thyroid disease and they probably have some autoimmunity. If there's a family history of thyroid disease, but you just heard of a patient who had a strong family history and it turned out to be a pituitary adenoma, so you need to be a little careful about that. You'll hear about pregnancy. There's some recent data that's actually very interesting. And it's very severe hypolipidemia is listed in here. I'm not so sure that, I mean, this is an old recommendation. I think there are better drugs now for treating hypolipidemia than using thyroid hormone. And there's a considerable risk with over-replacement, particularly in osteoporosis and in older people, atrial fibrillation. And also add to that, people who have a history of thyroid surgery or radioactive iodine. How do we treat in stable elderly patients? You start with a very small dose. You increase it gradually. I think many people in this age group tend to have coronary artery disease, so I often give with a beta blocker to avoid overstimulation. And then monitor the TSH, make very gradual adjustments in therapy. Avoid excessive stimulation. Do not let the TSH go down to 0. Monitor the TSH until the patient is stable, and then after that, you can do it once a year or so. So I'll stop and be happy to take questions.